continued on. And the class that graduated in June passed the American Board Written Exam, which is given A, which is the entry point into board certification. And then there's two other stages post that. There's the submission of cases, and there's an oral exam. And most people that take the written in May of the year they graduate take on to challenge one of the other two portions. Usually it's the oral exam, because the written exam requires some post-treatment evaluation. And while it could be a cool case, if the patient doesn't come back, you don't get post-treatment evaluation.
So you just need to change the screen as I'm sharing.
Okay, so of the four of them, one somewhere in Pennsylvania, one is in South Carolina, one is somewhere near the Arctic Circle in Canada, and the fourth one is in Reykjavik, Iceland. Of the classes will graduate at the end of June. They're pretty much on track on the number of cases and their research projects. Research projects always have question marks about them, that seems to be doing okay. And then the class of 2025, the four of them are here, Buddy, Pakistan, Sharon, and Evan, and they're doing really well. They have got research projects in regard while their clinical portion has got off with a bit of a rocky start. They're actually doing very well. Of the 2026 class, which I remembered at midnight last night, for the first time, I think, since I've been here, they're all Michigan grads, which I don't think has ever happened. If it has, it's been a long time. And then the last portion of this, A.M. Manipur is a non-degree, not quite sure what the current term is. Postgraduate. And he's a joint effort between endo and restorative dentistry. So Marco and I are sharing him depending upon clinic and Marco's schedule. And he's been here since August, Marco, or September? September. And then the last portion, the Zeiss, the Wolverine Crown, and Delta kind of all tied together. About 5 years ago, we started a collaborative project with Graduate Restorative, which became known as the Wolverine Crown project, initiative, whatever you want to call it, where if there was a mandibular molar that required a restorative portion, we came up with a joint procedure where we, being endo, would do the molar, Graduate Restorative would do an endo crown on it for a set fee of $754, split between the two programs. And last year, we got it towards the end of last year, we received a progress grant to work on this initiative, and we expanded it to include first and second molars, maxillary and mandibular, and if the patient was a documented veteran, the treatment was free. If the patient isn't a documented veteran, they're only eligible if they don't have any insurance. And so I'm just putting this out there because we are looking for patients as part of this initiative, because we received money from the provost for the provost initiative, and that enabled us, the endo portion, to buy another size microscope, except this one has built-in Wi-Fi, and you can stream the procedures to an iPad anywhere within Wi-Fi range of it. And it's also, we're in the process of getting it connected to a flat screen for teaching purposes, so you can stand there and see it happen in 48-inch color, or whatever the big of it is. So from Endo's viewpoint, it's not so much that we can't do the endo, we probably can. It's more, is the case suitable for an endoground? And so it has to be either approved by me or Bruno. And as far as the restorative part, Gazzelli, and I'm not sure the other restorative person is. Yeah. So we're looking, we're actually looking for more patients to put into this. And then the last thing, I guess this bit is separate. I put Delta Dental over the period of a year, which had its ups and downs. I got a grant from Delta to purchase a portrait unit. And some of you may know what it is, some of you don't. Basically, it looks like a conventional tube head that enables you to take 3D dimension in both coronal and sagittal views and not axial. And once we get through some more paperwork, we'll do a clinical trial with it. It has the potential to be hugely useful, maybe more for restorative dentistry than for endo. And that's it. Questions, if anybody has questions from anybody. Okay, yeah.
Neville, any thoughts about extending at some point the Wolverine Brown project to pre-docs? Any thoughts on that?
We've never had that discussion. I think the stumbling block, so to speak, would be to find the appropriate molar to have done by pre-doc. I actually don't see why we couldn't. We'd have to come up with criteria. The endo criteria would be slightly different. The endoground part, I think, would be more straightforward. Yeah, but we can talk about that. But that definitely would. That definitely has a possibility, but would be more limited.
Okay, thank you. Thank you, Neville. Thank you. Very good. So now let's see. Okay, now we are going to have the update from Switch Model.
Hi there, I appreciate you listening to some of the updates and changes that we've made in the pre-doc program in the past year or so. But I do want to thank my compadres. Tom McDonald leads the bunch of us up here in Endo, and then Tatiana and Bruno and I. And my focus tends to be this pre-doc program that I'm going to discuss with you. So at our AAE meeting this summer, our annual endodontic meeting, the pre-docs are all invited to meet every other year. And we have a theme that we go by, and we all discuss and exchange our ideas. And we have a few speakers and kind of commiserate on the troubles we're having in our teaching programs. And that helps us to know that we're all on the same page and teaching the right thing. But our theme was worth teaching, worth reaching, promoting and developing higher standards in endodontic education. So I kind of throw that out there because that's what some of these changes, and that's how we base what we teach here at U of M, of course, as well as following the guidelines that CODA presents to us. So that's what I'll briefly talk about, what we teach here at U of M and the new changes that we've made in the past year. So in the didactic courses, what we teach is in the fall of the D2 year, there's a principal of endo course, and it discusses diagnosis and case evaluation, more or less, and with a little bit of endo topics thrown in, but they haven't had their preclinical course yet, so it's more based on diagnosis perhaps and case evaluation. And then in the fall of the D3 year, following their spring course in between their D2 and D3 year, in the fall of the D3 year, they have a second didactic endodontic course, and that also deals or supports the diagnosis of case presentation or case evaluation, but it also addresses a lot of specialty endodontic topics. So those are the two didactic courses. And then in that spring, in between those two courses, as I mentioned, they have their preclinical course. So what are we teaching the pre-docs clinically? Well, right now, we're teaching the Wave 1 Gold system, which is presented scientifically, supported by the research as a really straightforward rotary means of preparing teeth endodontically. It's very safe and easy to use, but it does involve reciprocation, which is kind of like a back-forth movement of the rotary file. So the students expressed some concern when we went to this this method a couple of years ago that they were only being exposed to one type of rotary system. So we also teach a 360-degree rotation system, and so they use a vortex, or the system is vortex. They use an orifice opener in the top of the canal, and they learn the feel of a 360 rotary instrument versus that reciprocation. So, and then we teach, of course, rotary to the apex of the tooth. And then we're also, as you see in the picture in the upper right-hand corner, well, it's probably blocked in your screens by some of the guests here today. We teach, of course, hand file. You can't use a rotary in a canal until you've opened the whole canal up and develop what we call a glide path, or kind of a pathway with hand files. So in the event that students are in an office, or dentists, no longer students, are in an office that doesn't have a motorized or rotary system, they certainly can do root canals. And then we, of course, teach how to fill canal obturation with Bedford shock and sealer. So any changes in the past year or so? Well, no change in the science of what we teach. The science has been pretty basic with the pre-doc or the more entry-level root canals. But how we teach it has certainly changed, and I discussed what we're teaching and how we teach it. But we do have an improved preclinical learning environment. The ACE clinic is now open and fully functioning. That's that newer clinic that abuts the old, it's I don't even say the old sim lab, but now we have the sim lab that we had originally, and that's become the older clinic. But in the ACE clinic, there are 10 additional radiographic machines that we didn't have in the past. They used to run up to the first floor and use some of those, that patient area radiology, some of those units. There were only 5 available to us. Now we have 10 right down the same area that they're working preclinically. And we also still have the 4 cabinets that are in the old sim lab. So we have quite a few x-ray machines, which for endodontics is really important. It facilitates their learning. There's no lines or waiting for machines. We've also, COVID, not to ever mention there's something good about COVID, but of course we always look at the silver lining, and COVID taught us that having fewer students, a lower student to faculty ratio, facilitated their learning and made the ease of learning go more efficiently and quickly. So we do divide some of the lab courses in half, and we only have half of the students present. So it really has been beneficial to the students, and they will We always run changes by the students and the class officers, and then have discussions prior to making them. And the students definitely agreed that a lower student to faculty ratio really facilitated their learning. So now we have a lower number of students on many days and a higher interaction with faculty. And then for the School of Dentistry went through Blue Renew, and we were definitely on board in endo, but kind of the plan was with all the technology in all the specialties, that the specialties were gonna move out of the VIX. Now, some of them were already out of the VIX, like oral surgery and pedo and such, but endo had always been in the VIX up to about a year and a half ago. Since we moved into our own clinical area, the pre-docs are now interspersed in with the graduate residents. And so they have a lot more interaction with the residents, cross teaching. There's teaching from grad faculty in the pre-doc area now a lot more readily because we're all in the same clinic, and the pre-docs fit more easily into our clinic, or more comfortably, I should say, in the clinic. It's kind of their clinic now, instead of coming down to what we used to call grad endo and working in that clinic and observing. So now there's a feeling that they're welcome in that clinic and that they belong there. So it's kind of a win-win situation for both the residents who are more interspersed now with the less experienced pre-docs, and then the pre-docs, of course. We've also introduced a clinical rotation. So it started in the second half of last year, and now we're into our first complete full year of the rotation. So we never had that before when we didn't have as large of an endo clinic, and pre-docs were in the what called the regular endo clinic, but what used to be just the graduate clinic. So in this rotation, students do a variety of things. They work on a simulation exercise on a premolar and a molar. They assist one another as pre-docs, so they assist entry-level cases, but they also assist the residents. And now there's much more availability for the pre-docs when they don't have their official rotation day, to those that have more interest to be in the grad clinic or with the grad residents. So it is a much more dynamic, I think, learning space now that we have the endo clinic. And while there have been adjustments, certainly of being out of the VIX, and we certainly miss being in with the D3s and D4s as they're treating their patients in general dentistry, I think the advantages are pretty equal and they weigh one another out. So we're happy with how things are going. We're always open for suggestions. A few changes have been made with respect to colpectomies and instrument availability that we were overseeing only in our endo clinic, and now we've got some of those instruments, such as colpectomy kits, back down into the VIX for use by the generalists. But another addition that I want to point out, and we're still working out some of the details, is doing root canals on teeth that perhaps on a restorative level may be considered as non-restorable. In other words, most endodontic teeth that are given root canals in the posterior that need crowns restoratively to protect the root canal, and also to protect the integrity of the tooth. Well, with the patients that we manage on the level of the pre-doc and the fees that they're able to accommodate as patients, they weren't always able to get a root canal and posterior and a crown and afford both procedures. So we will do root canals on teeth that perhaps cannot accommodate a crown, but that can accommodate a core. That said, there really has to be really good interaction between the patient and the faculty in establishing that the ideal outcome for a tooth with a root canal in the posterior is a crown, and that with just a permanent restoration or a core, that there is a higher possibility for failure or breakage of the tooth. And that's the part, as I said, we're trying to work out and be sure that there's a good interaction and understanding. Because we had that guideline in the past, it wasn't an endodontic guideline, it was a restorative guideline. But as I said, we agreed because patients many times will express to restorative back with me. Oh, I can afford the root canal if I save, but I can't afford the final restoration of the crown. So anyway, that's something that we're working on among some other changes in the pre-doc clinic that haven't been established yet, but that we're working on with restorative dentistry. So this afternoon, I've kind of presented to you what the endodontic theme has been as we're formulating our programs and our teaching, what we present and what we teach. And then I've talked about what we're teaching here at the school, and then some of the changes which aren't minor or aren't major, but are kind of minor in what we've done. And so while I say think spring, we've had such a mild winter. We're probably thinking spring today and tomorrow. So whether or not we're going to get a real Michigan winter, time will tell. But anyhow, thanks for your attention.
So
Any questions?
Good question. The rotation that looks very promising there. And what do these students are able to do when they're in the D3 and the D4 rotations?
Yeah, the question is, what can the D3s and D4s do in their rotations? I talked about that, and when I talked about the rotation, there's three major things they're doing. They're doing root canals and simulated root canals on exacting what they do on the board for their endodontic procedure. So they're doing canals on patients, and they're doing simulated root canals to help prepare them for the boards and to make sure that they're competent. And kind of refresh the skills that they learned when they were in the preclinical area. Then they're assisting one another during those patient care exercises, and they are assisting grads and doing case studies on the grads patients. So when they observe a graduate or a resident in the endodontic program, they're not only watching the process and the technology that the residents use, but they're writing up the case to get them an understanding of diagnosis and all. So they get to talk to the resident if they have any question about, the case that they're doing and why the resident came to that diagnosis. So there's an interaction and a learning going on with respect to case studies for them. So, okay, thanks again.
Just a sec, please. Just see what question. So this is from Caroline. When do you anticipate being able to launch the pre-doc endo teeth with only the core as a final restoration? What details need to be worked out?
I don't, as I said, endo will do a root canal on any tooth when we have what the restorative discipline has established as an ability to do root canal on a tooth. So right now, restorative has a form that says that we can't do, or endo is to do the root canal unless it's signed both with the tooth being periodontally sound and being able to be restored with a crown. So endo is willing to do root canals on any teeth, so I don't know that it's an endodontic thing. I don't know what needs to be established. I think restorative has to, evaluate the situation with respect to when do they want us to do these procedures, and it's kind of a situation that is, I would have to turn over to them to answer for you. So I don't know the details on that. I just know we said, yeah, sure, we'll do root canals on teeth if you want the final restoration to be your core, but we've been told don't do any root canal unless this form, this restorability form is signed.
So for the legal, can you comment on this? Are we ready to talk about this, or do we need to work out the system first?
I think it's better because treatment is that the printout probably need to go because then we can bring cross to the game as well, because I think they can cross. we can put some background, like talking and then try to for the next academic year.
So any thoughts, Ron or Gisele? Okay, so let's try to get together soon and try to get this going as soon as possible, because the issue here, of course, is to give more experiences to our pre-docs, and if we can loosen up a little bit the criteria for what we would consider, not in terms of clinical restorability. The clinical restorability has to be one thing. The issue is when the patient can do the crown. I mean, some patients may say, you know, I will be willing to do the crown, I just cannot do it right away. And so that would be another situation where perhaps this could be implemented.
And maybe we can bring Sally to that too. I don't know if you guys have any plan to do like some facilitate the patient to have 1 day crown if it's needed to go and do some kind of in-house fabrication from the three docs.
That's a conversation that I didn't have with the level, you know, so it's to be determined, because initially, if you are looking to project down, and so we have a little right now, it's specifically a price for that for several reasons that we are not going to talk about. But if there is a need or a desire, then we have a nice probably visit that idea and everything that it can take for them.
Yeah, try to get together, Trish and me, maybe Sally, maybe Dawn, and like Mark Snyder, and we can try to line up this to implement next academic year.
I think it would be great, you know, to have you sitting together and figure it out if there is a need, for example, to change the form for for restorability, or if we have to change a consent form for these cases to address specifically this issue and make sure the patients understand that you know, while the tooth is with the core, it's more susceptible to the fractures and the loss of the root canal. But I would really encourage you to get together and we can help facilitate this sooner rather than later. Because I was talking with Carlos yesterday, our pre-doc students are really, they need more in cases. I think it's well documented now. And so we need to work with this.
Yeah, I don't want to drag this out too long, but I do want to say, you know, this evolved over the period of many cases where patients complained that they got the root canal, they got a core, and then the root canal fell, you know, the core fell out or came out or the tooth cracked. And then we had a lot of problems with then, you know, then we were responsible for an extraction and an implant or a replacement tube. And so between restorative and endo, if the form was developed, and we're talking within the past, you know, 3 to 5 years, the form has been very effective because the patient, while we know what we're thinking scientifically and restoratively, the patient listens, but they don't always understand. And then it comes up once the restoration fails, well, I didn't understand. Or the way our programs run, obviously, our students, you know, move on and they get a new student or a new dentist, and the new dentist isn't as aware of the history, perhaps doesn't emphasize the need for a final restoration. So anyway, I mean, we really want students to get more experiences. So as I said, we'd be glad to do canals on any teeth, but I think we need some restorative guidelines so that we all are on the same page and that the patient doesn't get kind of caught in the Okay, thanks.
Thank you. Thank you. Very good. So the next one is going to be, I think that is Gisele, right? Gisele, because Very good. So Gisele will give us an update on the graduate research program.
Thank you, Joyce. Hi, everybody. All of you. Hope everybody enjoy the holidays and stay healthy. I'm sure run into some viruses as they came back, but hopefully everybody's gonna be okay. So I don't have a lot to say, but stuff I have to say is good. Update on the grad program, made me think about where we were last year. The last year, it was a very rough year as far as the word that stuck in my mind was resilience. It called for us being together and believing that there was a light at the end of the tunnel. And the word for this year is grow. So we're ready to grow, ready to rise. We're working and in full speed, back to the full speed that we were looking for. And we finally have a team that has been rebuilt. So I'm going to spend just 3 slides to go over some of the highlights of where the program is, not just the program, but the clinic, because those splitting hats between directorship of the program and the clinic, so 2 separate things that merge really well together. But some of the things, and as we're ready to now rise from the ashes, like the phoenix. The good news, the best of the best news, the patients are ready to reestablish care. So we've been getting specific phone calls from patients saying, I'm ready, I'm done with this COVID thing, and then finally the fear is shaking off. Morale is up on the students, they're feeling like we're getting a better volume now. And our productivity is up thanks to that, and finally we're getting this movie here for us. Then as far as I always like to give you an overview of the students. It sounds like, why are you talking about 2022? Well, normally we have this talk in 2022. We just changed the order a little bit because I needed to address the curriculum and doctoral digital technology, so that took precedent. But so I want to talk to you about the class that just graduated in June. Very proud of them and very thankful to all of you that have contributed so much for their wonderful thesis projects. All of them finished on time, and I'm very, very thankful for your efforts, and I hope you continue to support the grad program in mentoring the students because we need your help. And I just enumerated, I guess I listed the mentors, whether they were co-mentors or whether you're part of the committee, majority from our department. So everybody's listed over there. From the students that graduated, 3 went into PhD programs. We had 2 that are currently in faculty positions in their home countries. 1 that is going back to be a clinic director, a program in the Navy. And the last one is applying, it's in the process of being accepted to the advanced study program here at the University of Mercy, because he wants to be in private practice. So he's going for the STD. G3s, which is our graduating class come spring, are all finalizing their thesis projects as far as wrapping up any remaining of data collection and finalizing analysis and trying to find a draft of their manuscript, so they're progressing well. As far as the second years, all of them are funded at this point and are either piloting or already in the first stages of data collection. In the first years that just started in July, all of them have identified mentors. Some of them have proposals written already, and at least one of them has a funding. So things are moving well. The students are well lined up for next year. For the class that will be joining us in June and July, the entering class, we're back to 7. As so far, all of them are fully matriculated. So we're expecting to have our team back from now on, back to having 7 every year. 6 of them are from Saudi Arabia, and 1 of them is from India. So all of them internationals. As far as our team, and I know you can't see it, but basically everything's new. So if you haven't come into grad restorative for a while, we moved a lot of staff turn around. Our clinic manager now, her name is Peggy Page. Peggy comes from the business office, and that has been a tremendous effort to the program. I can't even describe the money that we're finding and we're losing, and so many adjustments and things like that. She's finding all of that. So I think part of the productivity increases because of Peggy, for sure. And Peggy brought along with her also other members of the team, which I'm going to explain just in a little bit. So Peggy then coordinates 2 different types of activities: the clinic activity and the front desk activity. And in the clinic, we have Liz as our senior dental assistant. Liz has been here as long as I have, for over 22 years. Lisa used to be our clinic manager. She stepped down into a lead of an associate assistant, and she's really enjoying her position like such and working in a great team with Liz. Matthew, he's a lab assistant, and he's being instrumental to the point that we wanted to offer him a position as associate, but he is applying to dental school, and there's a good chance he's going to get it. So we will, work with Matthew as long as we can. So that I kind of roll into the topic that we are now posting for our dental associate, which is the last person of our team. We do use the works from the call center, Tanisha. So we have a person remotely picking up our voicemails and helping schedule. So then the team of hygienists, Julie and Shar, have been with us for some time, and they're working well. Saeed, this is the third person on the team, has just been accepted into dental school. So come May, we're going to lose one of our dental hygienists. And then just to wrap up, Jennifer is the person that came also from the business office together. So Becky brought her in from the office, and she's now leading our front desk activities. Mohammed has just been recently contacted also for shared services. And then we have Jenny. Jenny helps us also with the schedule and some 12 hours effort that she has. So I wanted to give you kind of an overview of the clinic, because this is the team, this is the people, this is how we roll, and thanks to all these people and the effort we put every day, it's how we can day to day continue to make sure that we fulfill our academic mission, that the students complete their learning objectives, and the patients are here and taken well care of. I have to say I'm very proud of this team. I'm very proud of the help that we receive from the faculty. We've had a very strong core of faculty that's been supervising all the activities in the grad clinic for a number of years. And I think the great part of success is because of that, because of people being the students, the staff, or the faculty. No major updates in the curriculum. We continue. We had a major review 6 years ago, and we continue to just gradually improve things. And I feel like we're now in the tweaking time of my time as a director for this group. So that's all I have for you. Any questions about the clinic or the program or the staff? Well, thank you for your attention. Thank you so much.
Thank you. Thank you, Susan. Okay. Our last on this presentation would be for the evening. And he's going to talk about radar restorative.
Okay, so it's a really quick update what we have been doing for the last 12 months, the restorative curriculum. Thanks, Carlos, to put us to review all the courses, and I'm going to present on Friday as well It's like a completely different way for the curriculum. That was really good because we're able to understand what's going on. So Andrea and myself, we were able to join to the code meeting last October to understand what the other schools are teaching and see if we're aligned with the other curriculums. We're pretty aligned. We need to change a few stuff and then even to revisit our goals and our vision. So really quick here, sharing what we have as a goal. So the first main goal is to establish the foundation concepts in dentistry. So when the student comes in as a D1, they go to the pre-clinic and start to understand like a little bit of concept of dental anatomy, a little bit of dental materials, and then operative one. Our foundation is like now is coming along with the whole other curriculum. You still need to implement some changes. And then that leads us to another main goal that is educate the dental students in the best available evidence and the latest proven technology to achieve and maintain patient oral health, comfort, function, and aesthetic to a risk-based diagnosis, prevention, tooth preserving management, and caries and non-caries disease to treat towards. So they're going to learn and then they're going to start to practice. So in that exercise that we're doing for CODA, so being able to revisit all the syllabus, all the course content, we are able to identify like one big gap that we have in the transition between the pre-clinic and the clinic, and I hope we're going to be able to address that pretty soon. So this is exactly what restorative does. We're in charge of 12 courses throughout the curriculum. So we go from D1 to the D4. So we get like the students start to thinking about what is dental science, how they can practice, how they can train their eyes, their brain to reproduce something the restorative way, a very solid foundation. I'm not going to talk much about the cariology, but we do have 2 courses. I think now we're going to put like a new ask for cariology in the D3 year that are going to help us because you saw it, they're pretty good in the D1, and when they take the D4, they say, okay, I forgot about cariology. Maybe it's like a lack of reinforcement, but we are touching base on that as well. So we are present all through the curriculum until they graduate. And so far, what I can tell comparing this year to the last year, we're going to talk about those ARP letters that are out there, how many students they are behind. We are much better than last year, especially the T4. So more patient, like more clinical opportunities for those students, and you're going to see some of them, they are struggling with some, we are trying to help. Thanks for the faculty coach that are working with the PCCs, and then we know getting better. And I think you're not going to have like a major problem by the end of the semester, maybe 1 or 2 students, but this is what we have right now. So, and with this, most likely what you went to go from pre-doctoral, like a basic science, going to the clinic, this is our philosophy, how we treat patients now. It's pretty much a patient-centered approach. And we are trying to change that. And for change that, we do have some ongoing tasks that we are trying to go to that every single day in clinic, try to revisit, try to come back, try to inquire, try to present some of the best evidence for our patient. And it's a lot of work that comes from like the very basic to align curriculum from the preclinical to the clinical to review all the didactic material, to review all the materials and instruments that we have in clinic, and then little by little propose those changes. So I listed really like simple ongoing tasks. So what we doing is reviewing and update all the course syllabus. We still have some syllabus that we are behind. That was another thing that we did during our curriculum committees, is to point out what we need to address. It's not only preparation from CODA, it's something that we need to be very consistent. So the horizontal and the vertical curriculum mapping, as I said, is a lot of work. Thanks, Diane and Carlos. We spend a lot of time, but it's as soon as you get that done, and I got this before, so for me it was not that complicated. It was kind of a little complicated when Diane sent me like a table, an Excel sheet in one day, and I counted the name of rows was 972 to go over, and I say, okay, what am I going to do here? A lot of copy and paste, but a lot of stuff. So we are able now to align at least the didactic parts from preclinical to clinical. So every single class. So today they're giving a class in class 2, amalgam and composite. So Andrea, Clarissa, and the whole team who teach them, we try to get together and see if we are carrying this over to the second year. that I am in charge of like the kind of advanced restorative course, that this one, I'm gonna propose something later on that I think we do have an opportunity to grow that course. It's not only being didactic, try to implement some sessions as a preclinical sessions as a second year. We're gonna pilot this, so Suman and me, we are working in like a small grant to see if we can do like a pilot, do like a pathway course and see how can we present that for the future. So we are reviewing all the instruments and materials to recommend to the MIS committee. So Jack and I, Clarissa, Andrea, and other people are going constantly talk to the MIS committee. Some of like pushback, but we are trying to get to the point that we really need to move in this and this and this. I was able to identify what people are not doing this or because of a lack of this type of instrument. So we are presenting and we are hoping that we're going to have everything that we are asking for the next academic year. So we are reviewing and updating all the test case rubrics, and both because of CODA and because I think we need to revisit. And some of them are going to propose some change, and then doing our calibration sessions are going to bring, and we are revisiting those rubrics and see what we can implement to make better. And maybe the test case probably now in the D4 year, since we're going to have 7 graded test case, we're going to discuss with Giselle and the digital dentistry team and see if we can take it out one of the digital scanning, because they are doing 2 as a D3, 2 as a D4, and now we're going to grade the outcome of care. So this is something that we need to discuss. Clinical calibration session, we're promoting like a monthly session, then to now going through all those rubrics, try to get the fact in the same page. Something that I learned not long ago, Jack, I think is going to be part of that. They are doing like a calibration in the pre-doctor, in the preclinical clinical foundation course. So there, Irene brought some like macro models. I never been like part of this, and I wanted just to see what they are doing. Seems like very nice to get the faculty what they are teaching. They have like macro models. I think they duplicate those models to be able to explain the student in the same way. And what are we doing right now? Some like CTCA training, and I hope you guys can join us for the next 2 sessions. So we promote like 3 sessions for the 3 docs that they are doing the boards on in March. So we have one coming on Wednesday morning. If we're not covering the clinic, if you have a free time in your schedule, come to help us. And the last one is February 8th. Okay, so those are ongoing tasks. And then we have some like challenge and future plans. One is revisit and change some restorative test cases, as I said, reassess the curricular opportunities to introduce a new pre-clinical course, like 7 weeks to help those guys to transition from D2 year. Then they are learning more advanced techniques, but they are not doing a lot of like preclinical work right before they go to clinic in the summer. So maybe late spring, try to book 7 sessions, and then we're going to do something that is going to be a continuance from the DENT-CRSE. That is an advanced restorative course that I'm directing that course as well. So we update the monthly faculty calibration format based on the feedback. We still need some feedback from those sessions, and explore a little bit more, as Jack just said, about endo, cross, interdisciplinary learning opportunities. Pretty much this is what I have. And I think we have 5 minutes for Jack to wrap up. Any questions?
Any questions, concerns?
Maybe a comment there.
Yeah.
But thank you for mapping the restorative, discipline. It's a really a huge challenge because many people, many courses, many years, but I think that the hope is that not only help the curriculum committee but also the department.
Yes.
Right? So we can all see what's going on at different places. And one thing that when you present to the curriculum committee, we will record that presentation that will be available to the department. So people, you can post it someplace or show it in a calibration session.
Because we're going to really divide, we're going to divide by color, you guys did, and then we're going to do like color by year and semester, which course, who's in charge, what we are doing. So I think it's kind of like a global vision. What those 12 courses, and then put like the cardiology apart, because Margarita already presented the cardiology curriculum that is apart from the restorative. So we can have those 2 send to John and Rosalind so they can send to everybody to see what you're doing.
Right, and I think as part of the onboarding for new faculty, you know, it's hopefully we'll have these 5-10 minute videos so they can very quickly get the big picture of what we're trying to accomplish from the day 1 to the day 4 years.
So I think that if after you presented the curriculum, and once it's all ready to go, we can actually have a faculty meeting dedicated to this conversation, because it's gonna be very helpful to all of us.
Yeah, but we present like 3 months ago and present on Friday, I think we're pretty done. And I don't know, Andrew, did they present already?
They do present
Yeah.
the next meeting will be one after that.
Good, thank you. So I'm gonna just have a very quick announcement to you. As you may or not know, Kathy, our administrator, now we are sharing again her with the school because our director of finances moved on to another job in December. So Kathy is taking over that position in an interim way. So for now, we are sharing. Kathy will continue to have her job as administrator for the department, but she's going to also be the director for finances for the whole school over the next months until we identify a new director of finances. So if you want to see Kathy now in the office, in the department, she's going to be there on Monday and Fridays. The Tuesdays, Wednesdays, and Thursdays, she's going to be in the first floor, close to Carlos' office. So again, Monday and Friday, Kathy will be in the second floor in our CRSE suite. Tuesdays, Wednesdays, and Thursdays, she's going to be downstairs in the first floor. Thank you all for coming.
Jacques, can I just add to your announcement? Jacques? Jacques?
But are you-